Welcome to State of Mind, being human and living well.
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 I'm your host, Deborah Sloss, and my pronouns are she, her. Today, we're going to be discussing one of the more impactful anxiety disorders, Obsessive Compulsive Disorder, commonly called OCD. OCD affects approximately 1 in 40 adults and 1 in 100 children in the U.S. and is equally common among men and women. The average age of onset is either between 8 and 12 in children or between the late teens to early adulthood in adults. And 1/3 of all affected adults first experience symptoms in childhood. As you will hear, OCD goes way beyond being a neat freak. It's an incredibly impactful anxiety disorder where obsessional thoughts and compulsive behaviors can take over a person's life, consuming hours of their day, restricting their lives, and leading to increasing isolation and suffering. It's not uncommon for patients to have years of treatment before getting properly diagnosed and appropriately treated. When left untreated, OCD can be chronic, while proper treatments can help sufferers regain control over the illness and relief from symptoms. So stay with us as we learn more about OCD and how to treat it as we talk with psychologist and anxiety treatment specialist Dr. Donald Dufford and educator and musician Lisa Taylor, who's been living with obsessive compulsive disorder since she was a teenager. So let me tell you a little more about our guest today. Lisa LaHooey Taylor is a transracial adoptee who moved to Santa Cruz, California from the Big Island in 2004. She's a professional vocalist, an early childhood educator, and a mental health advocate. In hindsight, Lisa says she had symptoms of obsessive compulsive disorder as a young child, but she wasn't diagnosed until age 15, when her symptoms worsened after her mother had a serious illness. A combination of medication treatment and psychotherapy have helped Lisa greatly. At the same time, she says she knows her OCD journey will always have its ups and downs. This is actually a welcome back to Lisa, who was also a guest on 2 past shows, so you may want to check out episodes 24 and 25, where Lisa was a guest on both Part 1 and Part 2 of the Racism and Mental Health series. Also with us is Donald Dufford, PhD, who is a licensed clinical psychologist and director of anxiety treatment services. He received his bachelor's degree from Rutgers University, master's from Cornell, and PhD in clinical psychology from Sierra University. Dr. Dufford trained at the Anxiety Treatment Center with Dr. Ed Bourne, author of the Anxiety and Phobia Workbook. Over the past 30 years, he's accumulated extensive continued training in treating OCD and other anxiety disorders, including panic, phobias, generalized anxiety, social anxiety, and related issues. He's a longtime meditator, Pacific Voices choir member, and has enjoyed living in SoCal, California since 1993. Today's interview was originally conducted back in 2021 and has been re-edited with new material added for today's broadcast. Here's the interview. Welcome, Dr. Dufford and Lisa.
Thank you.
Good morning. Thank you for having us.
How about we start with you, Dr. Dufford? Can you let us know what the diagnosis of obsessive compulsive disorder actually is? And does it exist on a spectrum like many other mental health diagnoses?
Yeah, first of all, the actual diagnosis is that the presence of obsessions and compulsions. So obsessions are recurrent and persistent thoughts, urges, and images that are experienced as intrusive and inappropriate and that cause marked stress and anxiety. Compulsions are any attempt to suppress, ignore, or neutralize the anxiety and intensity of the obsession. So it can show up in a variety of ways. I'm continually amazed at the different ways that OCD does show up.
Would you like to give some examples of that?
Well, the typical examples would be contamination issues, and the compulsions would be hand washing, excessive showering, avoiding touching things, and so on. The other most common way it shows up is in checking. So checking the locks, checking the stove, making sure it's off, and that sort of thing, or just checking numbers, letters, everything that's being done has to be repeated. Um, it could show up in just pure obsessions, which are intense, intrusive thoughts. And they can be very bizarre and scary. And that's how it loops into OCD is everybody has bizarre thoughts sometimes. Like, what if I just push this person off the cliff that's standing next to me? Or I had a police officer who had thoughts of, what if I just took my gun out and shot everybody in the room right now? Or parents that have thoughts about stabbing their child or something. And it's so intense and it's so scary that it starts to have a life of its own. And we want to avoid it, and then start to think about it, and would I do that, and could I do that, and then it just snowballs into recurrent obsessive thought. And compulsions, again, can show up in different ways. Everything from, like I said, hand washing to it could be mental compulsions. So repeating certain numbers in your head, or saying certain things, again, to neutralize the anxiety of the obsession. And that's part of the problem, is that it does create anxiety and stress, and then it affects normal functioning. And to actually meet the diagnosis, you have to have about an hour a day of uh, obsessions, compulsions. And again, it has to affect your daily functioning in some way. For a lot of people, that means just taking too much time to get ready or to get out of the house. They have to keep going back and checking. Or if they're driving and they hit a little speed bump or a pothole, and the thought comes in, the obsession, well, what if I hit someone? They have to go back and check and go back and check and go back and check. And the problem with OCD is that it's insatiable. There's no level of um, figuring it out or analyzing it that's going to make a difference.
So you are saying in some ways it exists on a spectrum, in that there might be people suffering who may not meet that 1 hour a day criteria, but still are really experiencing a lot of those symptoms and being affected by it.
Right. Yeah, the severity obviously can vary. And then there are other types of OCD. There's um, hoarding, as a little bit of a separate category. Um, BFRBs, body focused repetitive behaviors. So that would be typically hair pulling, trichotillomania, skin picking, nail biting, and that fits into OCD category as well. And body dysmorphic disorder, that's when someone gets very, very fixated on one aspect of their appearance. But it's not realistic. So I've had clients that they think their ears are too big, or their forehead's too big, or their head is out of proportion, or they just think they're ugly or whatever. I had this beautiful woman who thought that her appearance was grotesque, and no amount of reassurance could make a difference. And that's another thing with OCD. No amount of reassurance will really take it away. Temporarily, again, that's one of the compulsions, is to get reassurance from other people. That could be another way to neutralize the obsession, but it's only temporary, and it just keeps the cycle going, and it actually feeds it.
Lisa, I'm watching as Dr. Dufford is talking, I'm watching her head just bob up and down through so many things he's saying. So it's my understanding that you were diagnosed with OCD as a teenager, and I'm wondering if you could tell us what that experience has been like, both as a child and then as a teenager and then as you moved into adulthood. So what led up to the diagnosis to begin with?
Um, as you said, as I get older, I do recognize little signs from when I was really small. Just really an aversion to sticky hands and having my friends check my clothes to make sure they're clean all the time. And just thought it was, and everybody just thought, oh, there's Lisa. She wants to make sure her clothes are clean. And looking back, it's like, wow, those were definitely signs. Like I'd get to bed with my library book and I'd have to get up and wash my hands before I went to sleep. Um, I was officially diagnosed at 15. My mom got really sick and she almost passed away. And a lot of the sickness that she had, I ended up connecting it to something that I had done. And I thought my fear is around contamination. That's my major thing. So I thought that I had, by not saying something, allowed someone to take a bite of her sandwich at a rehearsal one day, and that person was sick. And when she got sick, I thought if I had just thrown that sandwich away, or if I'd told her, she wouldn't be sick. And now she's going to die. She's going to die of AIDS. And these things are guilt inducing because you don't dislike anybody or hate anybody for their health. But the OCD tricks you into feeling like, basically, I thought I had killed my mom. And so I started washing my hands and washing my hands and washing my hands. Her immune system was really weak. And so I was up to about 8 hours a day of washing my hands, just horribly long showers. I stopped eating because I didn't want to contaminate the food in the house. And luckily, pretty shortly after I started showing these symptoms, my parents had just happened to see like the show on 2020 about OCD, and it wasn't something that was widely known at that time what it was. And they got me into therapy pretty quick, which was tough where I'm from on the Big Island because the best therapy was off island. So we went in, I got some really intensive therapy, a lot of exposure therapy on medication, and I lucked out that worked pretty quickly with some adjustments. Um, so yeah, it's been contamination, a lot of washing, and just being deathly afraid of not not even as much of me being afraid of being sick as getting somebody I love sick. That is my worst fear.
I can only imagine how that has been during the pandemic, and I think we're going to talk more about that as we go on.
Yeah.
But as you grew up and into it, matured into adulthood, how did your symptoms change at all? Did they? And how does it look different now in your adulthood?
OCD is really interesting in that way. There are certain things that I think back and I go, wow, I was afraid to eat spaghetti sauce because it was red. And I was worried if there was blood in it, I wouldn't have been able to see it. And now it's like, wow, okay. I That's not something that would concern me at all. Um, it really morphs. I mean, it's like a roller coaster. You have certain things that you obsess about, and then those can go away after a while, and something else can take its place. I still do a lot of hand washing, not nearly as much as I did, enough for people to notice. Um, and now it's like new things have taken place. Like I'm completely terrified that I'm going to hurt my cats in some ways. I'm really careful with cleaners, and I'm really careful about, oh, I touched a closed chocolate bar. I still have to wash my hands, or when I take my medications, I got to wash. I'm really worried about, it's still all around someone dying though. And I have a lot more picking during the pandemic, especially. I've been home and just picking my fingers like crazy in my face. And so I've got definitely have body, what do you call it? Impulse control things going on. And the ticks that kind of come and go, they've been getting a little stronger lately. Last week was really stressful with the George Floyd case coming to a close, and so the ticking has just been, and the little hiccups and little auditory, you know, ticks they've gotten a little worse. It's something that just is ongoing. I've learned to manage it, which is the major thing. But there are always, with OCD, there's always something that can pop up. And there are certain things where you look back and you go, wow, I'm taking 20-minute showers now. I used to take 2-hour showers. So I make sure that even on a hard day, I give myself pats on the back because I've come a long way. It can still be really frustrating and um, hard to live with, and you just think, why can't I just be quote unquote normal? But I also give myself a lot of pats on the back because I know that when I was first diagnosed, I could only dream of living the life I am now.
Can you say a little bit about those things in terms of like that you only dreamed of, like that might give other people listening some hope?
Well, like you brought up the pandemic. I mean, my whole world is centered around contamination and not getting contaminated. And well, I should also say that I've decided to become a teacher. So I'm dealing with, I mean, people that don't have OCD go, but kids have cooties. Like, how can you, how can you do that and have OCD? And I've really looked at it as exposure therapy. I had to put myself in that mind frame of, okay, I love kids. With the kids and the singing, those are two things that I really, really love doing. And for some reason, with OCD, that can quiet it down a little bit. I'm past the point of in the past where it would quiet down, but it would come back even stronger lately because it was like, okay, I'm doing this, I'm able to push this down right now. I've got a big performance. And then later on, it would just it hit me even bigger. I've gotten to the point where I can get through things. And when I'm done with a performance or done at school, generally I'm feeling okay. Um, it's important to do things. And this last bit of exposure therapy I went through a couple of summers ago made all the difference because it's scary to do exposure therapy, but it works. It really, really, really works.
You're listening to State of Mind, Being Human and Living Well. I'm your host, Deborah Sloss, and I'm here talking with psychologist and anxiety treatment specialist, Dr. Donald Dufford, and educator and musician, Lisa Taylor. Stay with us to learn more about obsessive compulsive disorder, treatment options, and much more. Back to our interview. Coming back from the break, I thought I'd turn to you, Dr. Dufford, and I'm wondering, as you listen to Lisa's story and description of her experience of OCD symptoms, what about her story is common and what stands out perhaps as unusual or unique?
Well, what's common is that OCD often flares up under times of stress, and sometimes it can get stimulated initially by trauma. So when you talk about your mother being seriously ill and how that affected and increased your OCD symptoms, that's typical. And sometimes OCD can kind of be in the background, and then again, something happens in life, and there's that stress and that sympathetic nervous system arousal that kicks your brain into that looping, getting stuck with OCD. What's really good about your process is that you have the insight and the awareness that it is OCD. If someone doesn't have that, it's very difficult to treat, obviously, if they really believe that contamination, or contaminating other people, or whatever the obsession is, if they believe it and can't separate from it and detach, then it's hard to make any progress, right? So you have good awareness and insight, and that's really been helpful throughout the years, apparently. Also, when you're doing the initial ERP, you also are taking medication. That can be helpful. However, research shows that comparing just ERP just medication and ERP and medication together is if you don't do the ERP.
Can I back you up and just ask you
Yeah.
to define ERP for our listeners?
So yeah, ERP, exposure and response prevention. So that means you're exposing to the OCD trigger, whether it's touching something you think is contaminated or whatever triggers your OCD, and then not engaging in any of the compulsions or rituals, again, to neutralize that fear, that obsession. So you're exposing to it, you're bringing up the OCD, you're bringing up the anxiety, and you're sitting with it, and you're not doing any response prevention. So that's ERP. And and you also mentioned, Lisa, that it's hard sometimes, and it's difficult, and it's challenging because you're doing the opposite of what OCD and anxiety is telling you to do. So congratulations for standing up to OCD. That's the way out of it, is to stand up to it. And then medication versus ERP. So taking medication alone can sometimes bring relief, but after stopping the medication, OCD will come back. But if you do ERP with the medication, then you'll get more lasting results.
Can you say something about just not specific medications, but what is the broad classes of medications kind of that tend to be used for obsessive compulsive disorder?
Yeah, typically SSRIs. So you've heard of Zoloft, Prozac. Zoloft is really the most common when prescribed, or sertraline is the generic name, which produces more serotonin in the brain and just helps to kind of turn down the volume on some of that intensity of the obsession and the compulsions. Yeah.
To go back to what ERP and medication versus just medication, it's so true. When I mean, the exposure therapy with the medication was so instrumental in basically saving my life when I was diagnosed, because I was in school. I could not function. I could not go to school. It got to the point where the only person in my family that could touch me was my mom. And one day everything was contaminated in the house except for my room. And one day my doorknob got contaminated, and the tissue box that I was using to open doors got contaminated, and I had to call to be let out of my room. Things were really bad. And once you get those skills, the medication helps you get to that point. At least for me, it helped me get to the point where I was able to do exposure therapy. It wasn't right off the bat. It was, I think, maybe a few weeks into my therapy or a month. And more recently, I was on medication. I had a doctor, and I wasn't, he doesn't specialize in OCD. So we go and kind of chat, and it was nice, really nice guy. But I mean, he didn't treat OCD. And so I was taking medication, and the appointments were getting farther and farther apart. And I realized that I was on a major roller coaster of anxiety. And that's when I realized that, primarily for myself, I need to get serious and get proactive about my mental health. But also, I have such a loving, caring partner, and we're a team. And he doesn't know what Lisa he's coming home to. Is it going to be happy Lisa, sad Lisa, freaked out Lisa? I mean, like, suicidal Lisa. He didn't know. So it was really time to get serious.
Lisa, just listening to you talk, it really strikes me about how your world was getting smaller and smaller and smaller to the point at which, it was just your room, and then even that wasn't small enough. And, I think about that when in the people I've worked with impact of anxiety, all kinds of anxieties. And I thought maybe this would be a place, Dr. Dufford, you could talk about why the obsessions and compulsions become so disruptive to people's lives. Could you describe some of that from your experience?
Yeah. It becomes so disruptive because if gone untreated, it just gets get more intense, and it tends to generalize, and it tends to get worse. So, a half an hour shower isn't enough. Then you have to redo it, and it becomes an hour or 2 hours. And again, OCD is somewhat insatiable, and there's no amount of compulsions or that will satisfy it. So it tends to just get worse. And um, cautionary tale, the movie The Aviator with about Howard Hughes. So he was someone who absolutely had the resource to totally indulge his OCD, and he ended up in a room by himself with people having to, you know, put food in the door for him, and sitting there naked. He couldn't touch anything. Um, if he's on the phone, he's afraid that contamination is going to come in through the phone line, and so on. So it just tends to get worse, and it is disruptive. All the rituals and compulsions that have to be done, and so on. So, but I wanted to go back a little bit to what Lisa was saying, and that she's afraid of contaminating other people. I've had a lot of clients who had the opposite, where family members are contaminated, and so they don't want to be touched by a family member, or they don't want to touch something that a family member has touched. Um, and another thing about ERP is that because it is challenging, usually I'd like to start with some intermediate steps, just like delaying it. So if you want to wash your hands, well, maybe I can wait 2 minutes, and maybe I can wait 2 more minutes. So you start to push back a little bit against the OCD, or kind of just do the ritual or compulsion in a little bit different way. Kind of mess with the OCD, and instead of counting to 10, you count to 8, or instead of washing 5 times, you do it 3. So usually when we start, we'll list everything, all the obsessions, all the compulsions. We'll rate the intensity of each one, and then you start with the ones that are lower intensity, and you work on those first. You get a little bit of a mastery of it, and you get a sense of like, oh, ERP does work. And then you kind of move up the ladder of hierarchy scale to get to, what seemed to be impossible at first. Now it's just the next step.
So I'm wondering if there are any misconceptions about OCD that you'd like to set listeners straight about, either one of you.
Well, you're not crazy. And, a lot of times you hear people say, oh, I'm so OCD. Yeah, right. So OCD is not just being neat and clean and focus on cleanliness. It's much more intense than that. It goes beyond that. And you can't just stop it. Some people think, oh, well, just don't do that. Just stop it. That's also not realistic. And you're not overreacting, and so on. So some of the misconceptions that people who don't have OCD can see it very differently, and not give it the credibility that it needs to have. And people also kind of sometimes get into giving reassurance. It's another misconception. Oh, if I can just reassure you that, Lisa, this is not contaminated, it's really okay. That may actually work as a compulsion to give you some relief temporarily, but then again, it's going to come back. It's going to come back. It's going to come back. You're just reinforcing it. So people need to know that giving reassurance is not helpful. It's just you're being sucked into the OCD loop, right?
Anything, Lisa, you'd like to add to that?
Yeah, I mean, people say, "Oh, I'm so OCD," and I'm like, "But are you really?" OCD is not cute. It's not something to just throw out. Oh, it's my OCD. Oh, I'm so OCD. I mean, I've seen posts on Facebook about, yeah, I wish my OCD friends would come clean my house. Like that. if a person with OCD came clean your house, they wouldn't be in there like, Mary Poppins singing and whistling. It would be traumatic. It would be hard. They would be stressed out. It's not something we do because we enjoy it. It's something we do because we have to do it, because the chemical imbalance in our brain is telling us, you need to do this or your mom could die, you could die, somebody you love could get hurt. There could be an earthquake. There could be, across the world, there could be a tsunami that kills hundreds of people. I mean, this is not something that is enjoyable for any of us. And people that, oh, your house must be so clean, you have OCD. I've had places I've lived where there were just piles and piles of things because guess what? Somebody bumped into me outside on the street and I thought that person was quote unquote dirty. And I came home and I threw that in the corner with all the other stuff that I don't want to touch and avoid. And you know what? My apartment is an absolute mess. And I've got my bed that I feel safe in. Um, it's like the Seinfeld episode where Elaine's like, "I'm gonna can I drive some trash to the landfill?" And he's like, "My car was my last germ-free sanctuary. I slept there last night." Like that's how it is. You have your germ-free sanctuary, the rest of it's contaminated. And I really wish that people the reason I speak so loudly about OCD and anxiety disorders is because people don't understand them. There's such a stigma about it. And when you hear somebody going, "Oh my God, I have to have my books exactly right." They could have OCD if that's what's going on because they like the way that looks. Probably not. Um, or if there's a meme going around Facebook and all the candies aren't perfect and oh my God, my OCD is so triggered. I'm like that. I wish it were that easy. I wish it were that cute, but OCD is not cute. I mean, I almost didn't make it. It's
Mhm.
horrible.
I really hear that you want people to know that, behind those behaviors are this tremendous level of distress. And yeah, you really get that point across well, I think, Lisa.
But it is treatable.
It is treatable. It absolutely is.
You're a great testament to that.
Do you want to say anything more about that?
Yeah, I think that's one of the misconceptions is that you're stuck with it, and um, but it is treatable, and you can get through it and get better. Sometimes it you have sort of remission, and like I said, sometimes in times of stress it may flare back up, but then you know what it is, and you have the skills and the tools to separate from it and label it and let it go by.
Well, along those lines, Lisa, do you want to say anything about what kinds of treatment you've tried over the years and what's made a real difference for you?
Yeah. I was really lucky that my parents caught on very quickly to what was going on, and I have supportive parents. There was no like, "Oh, wow, what's wrong with her? Oh, she's crazy. Oh, just stop." They realized really early on that I needed to get help, professional help. They found me great doctors. I had a psychologist and a psychiatrist. I went to therapy in the beginning, I think a couple times a week. And then the exposure therapy started not long after. And I mean, I think back to the day that I started and just being petrified to eat, to touch anything, to go anywhere. We had to stay in a hotel because it was off island and just staying in a hotel. What's that spot and what's that? And um, to the day there was a chair that I had to sit in the office and I would try to avoid that chair because there was a spot on the side. And one day, I feel like it was maybe weeks or a month into my treatment, I went in and I just touched the spot. And that was just those things to other people that don't have OCD might be like, you touched a spot, big deal. But it was, to me, that spot could have been blood and I could have like died or gotten my parents and my family sick. So going through that and exposure therapy, um, years gone by, it goes up and down. And there were times when I didn't want to be on my medication and I would go cold turkey on my medication. That presents a whole issue of problems itself. That's not a good thing to do. Don't do it. And just being back into therapy with doctors that didn't specialize in OCD and realizing a few years ago, just like, I need to get serious. I need to get back into therapy. I can't just take medication. Like Dr. Dufford said, the difference between just medication and ERP therapy, just life changing. I got accepted into a OCD group over the hill in Campbell. And that, for me, for some people, maybe the group setting would be scary. I was nervous because I mean, I'm a dork. I'm pretty socially awkward. But being there with a group of people that some of them had the same things that I go through. Some of them had other things where I was going, I didn't even realize after all this time, I feel so knowledgeable about OCD. I didn't even know that was OCD, and I do that. And just being able to cheer each other on was huge. And especially when you're in the setting of doing ERP and it's scary, and to have other people there that were scared too and nervous too, but they were doing it. There was a lady there that had the same contamination fears, and we both had just terrified of touching door handles or like a shopping cart. I think I was ready to touch a door handle before a shopping cart. And she came in and was like, we set our goals for the week, our homework, and she came back and she said, I went shopping, touched the shopping cart. And I was so proud of her. And I just thought, you know what? She did it. She survived. It was just as scary to her. I can do this. And so right before the pandemic hit, I was opening doors and pushing shopping carts and holding carts. And just even after it started and we were hearing about COVID, I was like, I can't stop, because I finally, after 20 years of my life, am touching doorknobs and going shopping and not carrying things around. I can't stop now, or else I'll never be able to get back to this. So even after it had started, I was still touching things, and then we shut down. So the couple of times I've been out, I have used tissues to open the door. But, right now, I'm not going to beat myself up about that, because there's so many other areas that I'm doing really well in. And I'm like, I'm going out. That's my ERP right now. And those are going to be the steps. Next, I'll have to start touching things.
And for anybody coming in, I just want them to know that's exposure response prevention therapy.
It's life-changing. It really, it gives you the tools, because those thoughts are going to be there. And also, something that really helped me was just, instead of trying to rationalize every little thing and chasing your tail around, just saying, if I'm freaked out about something, I say to myself, you know what, you're stressed right now. That kid, sneezed, and that was gross, and you're stressed right now, and that's okay. And you're going to get through this, because you have before. And just ride that wave. Because if you try to push it down, then it's like, then it really just explodes. And I've learned to just ride it and give myself permission to feel it. And like, look, you did that before. You've gone into plenty of public restrooms. You didn't die. You didn't catch a disease. You're going to be okay.
You're listening to State of Mind, Being Human and Living Well. I'm your host, Deborah Sloss, and I'm talking with psychologist and anxiety treatment specialist, Dr. Donald Dufford, and educator and musician, Lisa Taylor. We're discussing one of the more impactful anxiety disorders, Obsessive Compulsive Disorder, commonly called OCD. In this next segment, we'll be talking more about how our guest found help, treatment approaches, and more. Every State of Mind episode has a resource list, and any we talk about today are included in the show notes. We're also now adding transcriptions and access to listening and viewing with closed captions. Go to www.stateofmindmedia.org to access all that material and learn more on this topic. Now, let's get back to our interview. Dr. Dufford, are there other things you would want to say about treatment approaches that are effective?
Yeah, I think I usually like to start with dealing with the obsessions first, and to do some, and mindfulness training is part of that. So to be able to kind of figuratively sit up and back in your head and observe your thoughts, observe your sensations in your body, observe your feelings, and to realize that if you're observing all that, then the consciousness that you are is not your thoughts and not your sensations and not your feelings. So to really get good at being the observer. And from there, we can realize that the OCD thought, the obsession, is just a thought. And we can accept that thought, let it be there, and not have to figure it out, not have to analyze it, not have to get rid of it, but you just let it be. So if it's OCD, let it be. Also, with the associated anxiety and intensity that comes up with it, again, just to let it be, just observe it. And I like to label it, it's a false alarm. So yes, you're feeling it, the alarm's going off, but there's no fire. There's really nothing to be afraid of. So it's a false alarm, and we'll just let that pass through, and we'll breathe, and we'll focus on something else, and so on. So I think it's important to label it. It's OCD, not me. It's OCD, not reality. So you're labeling it, discounting it at the same time. And if people aren't sure about, well, maybe it's not OCD, maybe it's real. Well, if there's doubting, sometimes we call it the doubting disease.
Yep.
Doubting, uncertainty, and have to. Duh, is it OCD? Well, duh, DUH, doubting, uncertainty, and have to. Yes, it's OCD. So I'm just going to let it be and refocus. So that's where we like to start, and getting that little bit of detachment, being able to label it and let it be. It takes the energy off of it. Now with little kids, maybe it's a monster or a bully, again, kind of separating from it. It's OCD, not me. And you can have fun with it with kids, and some funny looking, monster, and dress it up in a tutu or something or whatever. But and then we want to get into starting to do the ERP work. And as I mentioned before, we start with maybe just delaying the compulsion, wait 2 minutes, 2 more minutes, 5 minutes, then maybe you get caught up in something else and you don't end up doing it that day. Or maybe it's too intense, and after a few minutes you go ahead and do it, but at least you had a little bit of pushback, a little bit of mastery with OCD, because the way out of OCD is, again, to do the opposite of what it's telling you and ultimately not give into it.
I definitely also heard in Lisa's story how important it is to celebrate the success. Even though there's more challenges ahead, to like take that pause and see what you've done already or what you've been able to do that you never thought you were going to be able to do. I definitely heard that in your story. And I notice in my own work with people, sometimes we really have to train people to pause and celebrate.
That is really important. To every little piece of progress is really important. It should be celebrated. Absolutely. Yeah.
So as we come to the end of our time together, I'm wondering, if someone is living with this condition and, you, Lisa, have found ways to live a full and productive life and connected life, even in the face of the pandemic. So what advice, like one small piece of advice that you'd want to offer to a listener who might be struggling themselves, or maybe they have a loved one who they think might be struggling with OCD?
Well, I would say if it's you, don't give up on yourself. It's so easy to beat up on yourself and to even hate yourself because of the things you're going through. It's not your fault. It's a chemical imbalance. It's nothing you did. And you can get better. You can get help. Your life can change. The life that you might be wishing right now you could have and thinking you never will, you can have that. I've gotten there. and it's a daily struggle. It's something you're always going to work on every day, but it can get to a manageable point and where you can live. And at certain times, it feels like you can't because you're so consumed with everything. But you can get to the point where life can be good. You can do it. And if
Okay.
it's somebody that you're watching that's hurting, I mean, like Dr. Dufford said, it's so hard not to reassure, but that is feeding the beast. And I can't imagine being a parent or a spouse or a friend of somebody that has OCD really bad, because as an instinct you want to help. I think the best way you can help them is to encourage them to seek help, because it works. It really does. It really does.
Yeah.
Yeah.
Dr. Dufford, is there any one piece of advice you'd want to offer to listeners?
Well, again, the bottom line is to get help, and it is treatable. Um, Not only OCD, but all anxiety disorders are treatable, whether it's PTSD or social anxiety or panic disorder or generalized anxiety and so on, insomnia. It's treatable, and so to get help, and it can get better. Um, I've been doing this kind of work for probably 30 plus years, and that's the only way I can keep doing it, is because I see people get better
Hmm.
and live their lives in a more productive, positive way.
In Your Voice are short segments where listeners get to add their voice to the discussion. With regards to this topic, we heard from this community member. Here's Madison.
Hi, I'm Madison, a lived experience clinician who specializes in OCD. I make content at Obsessively Strong on Instagram and TikTok talking about my OCD journey, which you'll hear a little bit about here today. Outside of that, I'm an avid weightlifter, reality TV junkie, and an introverted extrovert. But for most of my life, these activities and more were taken from me due to being misdiagnosed for 15 years, when in reality I had OCD. When I found out, I immediately started ERP, exposure and response prevention, for my schizophrenia and depersonalization and derealization OCD, which was the most intense and difficult theme I have ever had to deal with. After about 9 months of ERP and about 70% improvement, I still felt stuck. And that's when my amazing therapist suggested inference-based cognitive behavioral therapy, which, if I was willing, she'd learn along with me. I-CBT changed my life. Even prior to the diagnosis, I always questioned why I was so anxious about some things and not others, and why no one ever felt like the reasons I was scared were valid. I-CBT kind of felt like someone took a look inside my brain and said, I see the problem. It's how she's reasoning. I-CBT is an upstream modality and focuses on the cognitive components that lead you to believe your OCD doubts are true. Through this, I was able to face the inferences, or reasons, my OCD was using to compel me into its narrative. This, along with learning about my feared possible self, pulled the veil away from my OCD. It gave me control to see what tricks it was trying to play to suck me in. I had tears in my eyes the moment that I saw that my feared possible self was being helpless. It just felt like everything had clicked. It felt like everything I'd ever been afraid of made sense. It was the algorithm of my OCD, and my feelings related to my OCD were not evidence of them being true, but a byproduct of my belief in those doubts. After the psychoeducation piece, the emphasis on tuning into the here and now reality and actually being able to work on self-trust truly changed my relationship, not only with my OCD, but with myself. To go from fearing and not recognizing my own brain to comprehending how it works and choosing to trust myself, my common sense, my logic, and my real self that's always been there, felt like I was learning how to live again in the same way I do in non-obsessional situations. At this point, I am so grateful to be subclinical, and it's led me to a life based on self-trust and achieving my dreams of helping others with OCD instead of a life based in fear.
Thank you, Madison. Now, we have something special to share with you that I am so excited about. A song written and performed by today's guest about her experience of living with obsessive compulsive disorder. It was released in 2010 and is available on Amazon Music. This version is bleeped, but for an unbleeped version, see the show notes for this episode. Here is Just Breathe, performed by Lisa Taylor.
Stuck here in my little room, counting and counting the days until I'm free of this prison I've created. Why must the world go on without me? Why must I watch my dreams fade? So many things that I want to do with my life, but I find myself stuck between these four walls, so consumed with the thoughts that are never ending. The self-loathe that makes me loathe myself more. I'm so sick of crying, but my hands are on my body sore. Can't stop myself from thinking about the problems of the world, the what ifs in life. Water on my hands helps to dull the counting in my head. If it sounds crazy, that's 'cause it is. Breathe, 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 I try to sing away the pain. I try to drink away the pain. I try to drink away the pain. I try to suffocate the pain. I try so hard to count my blessings, but sometimes it gets so damn hard. I try my hardest to see the lessons in life. I've got the smiling down to an art. I know the world is still turning, and I'm still sitting here worrying. Then I stop for a moment, I realize I need to just breathe, 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 breathe,
You've been listening to State of Mind, Being Human and Living Well.
And living well.
And living well.
living well.
And living well.
I want to say a huge thank you to our guests today, Lisa Taylor and Dr. Donald Dufford. And thanks to you for joining us. To learn more, check out the wealth of information included on the resource list in the show notes for this episode. New episodes of State of Mind exploring mental health and wellness are released the first Sunday of every month and can be found along with our complete archive on our website at www.stateofmindmedia.org. If you missed part of this episode or you just want to hear it again, subscribe to our podcast on all the major podcast platforms. Also, when you rate and review our podcast, you really do help it get found and heard by more listeners. So if you like this one or any of our episodes, could you please do that for us? Special thanks to our team, Jeannie Baldzikowski for audio production, Patrice Vecchione for story coaching, Patty Palmer for transcriptions, Rebecca Levy for media outreach, and Katrina Tattenham for research. And thanks to acoustic guitarist Adrian Legg for composing, performing, and donating the use of our theme music. State of Mind was developed and originally broadcast in association with KSQD-FM in Santa Cruz, California. We always want to hear from listeners and community members just like you. You can submit your very own in your voice story recording and become part of the conversation, just like Madison did for this episode, by either calling in to leave a message or record an audio file right on your phone. Either way, tell us about a mental health experience you've had, something that's contributed to your mental health recovery, or share a resource that's been helpful for you. Upcoming show topics are on demystifying the special education process for parents, and another one on teens discussing the role of social media in their lives. If you have experience with either of these, we really do want to hear from you, and your voice may just be on one of our future shows. Submission details can be found at www.stateofmindmedia.org. Come on back and join us next month for a whole new episode of State of Mind. Until then, live well.